Hello, everyone. My name is Anthony Capito. I'm a plastic and hand surgeon at Carillion. We'll be talking about skin cancer of the hand and upper extremity. I have no disclosures. First, we'll look at the histology or anatomy of the skin. This is going back to your medical school days of the different layers. At the base here is the dermis with the basal layer, and then there's the stratum basale, which is the reproductive layer of the cells. These cells will eventually migrate more superficially, become keratinocytes, and then have different layers throughout, finally becoming the stratum corneum, or the dead layers of cells, or dead cells with keratin. There are also some specialized cells at the basal layer, the melanocytes, which can differentiate into melanoma. There's also Merkel cells, which are especially sensory end organs that can give an aggressive type of skin cancer that we'll talk about at the end of this lecture. But these is the basic histology of skin. Looking more in depth of the skin, the residual layers are the dermis, which there is the papillary dermis, which is adjacent to the basal layer of the skin, and then the reticular. Beneath the dermis is the fatty layer of tissue where you have your blood vessels. There are sweat glands and hair follicles in the dermis, which gives rise to some epithelialization properties that we can see with some wounds that are very shallow. But the majority of skin is replicated down here at the metabolically active layer at the stratum basale. And it takes about 6 weeks for the cells to replicate and go through the differentiation to multiple layers until they're finally shed off at the stratum corneum. The stratum lucidum is here. This is in glabrous skin, as in the palms and soles of the feet. So why are we talking about this today? It is quite common. Over 2 million cases occur yearly, and it has an expensive cost to the healthcare system of over $500 million. And importantly, for our talk, 15% of these will occur on the hand or upper extremity. If you look at the hand, there was a review series of 541 skin malignancies, and they looked at which type of skin cancer and where was the most common location on the hand. And they were looking at squamous cell, basal cell, a benign variant, keratoacanthoma, as well as malignant melanoma and other skin lesions. And they found that the incidence, the majority were squamous cell, about 78%, followed by basal cell 11%, melanoma 4%, and a keratoacanthoma, which is a benign, can be aggressive type of skin lesion, about roughly 6%. So by knowing this information can help you with your diagnosis. You can see here on the top, this is the squamous cell. If a tumor in a skin lesion is located over the P1 or P2 area, has a high likelihood of being a squamous cell if you think the lesion is malignant. Also over the web spaces and over the MCP joints. And then 66% occur on the back of the hand. If we turn our attention to a basal cell, you can see it's less common in the web spaces or on the digits themselves, and highly common on the back of the hand. And then if we turn to the most aggressive type, malignant melanoma, 14% are on the palmar surface, and then you get the subungual. So if you get a nail type of aggressive tumor and that's pigmented, you have to think of malignant melanoma, and then 47% on the back of the hand. The keratoacanthoma, which is a benign skin lesion that looks bad, will progress rapidly then self-involute, but does have a small percentage of chance of turning to a squamous cell. The vast majority are on the dorsum of the hand. So just by knowing the location of the cancer, you can kind of give a differential what type of malignancy or the differential of a keratoacanthoma it can possibly be. So what causes skin cancers? Definitely sun exposure. This is well studied and well linked. There's UVA and UVB radiation. UVA penetrates 40% deeper and goes down to the dermal layer, and UVB is what causes burning. This is mainly absorbed by the epidermis, and this is the reason why we age, we wrinkle, and the reason why our skin can be prone to injury and develop these malignancies. These are both linked, And even on a cloudy day, you think you're not getting much sun exposure. These rays of sun with UVA and UVB are still 40% reach our atmosphere and are causing damage to our skin. So don't feel like you're protected on a cloudy day. You're still getting sun exposure. Any type of skin talk, we'll talk about a Fitzpatrick skin type classification. And it goes from lightest, fairest skin, type 1, to the darkest skin, type 6. And they usually talk about burns very easily, never tans, to the most extreme, never burns, never is already tan, very dark. The higher risk are the redheads in Fitzpatrick's 1 to 3. This is a risk factor of developing skin cancers, both non-melanocytic cancer as well as melanoma. So when we go and ask you to see one of these patients, you should get a detailed history of the lesion. When did it first appear? Has it been changing? Has it been changing in color or size? What are their risk factors? Have they had skin cancer before, which is a high indicator that they may have additional skin cancers, where they have a lot of childhood burns. A lot of the injuries occur in our childhood years, and skin cancers come many years later. And then were they in the military? Were they exposed to some type of abnormal chemicals? We see this at the VA hospital a lot, or any type of radiation repetitive exposure. And if they've already had a biopsy, you need to review that, figure out what type of skin cancer, as well as a subtype if possible, and whether or not there is positive margins, because that will dictate what your treatment that you offer your patient for the next step. Please measure the skin lesion. I frequently ask the residents how big it is, and they say 1 to 2 centimeters. Well, that makes a big difference, because when we treat these, we're going to excise additional margins. And with the additional margins may not allow for primary skin closure. And by telling me this is a 1 centimeter lesion, I'm already in my head thinking that we can get this closed, as opposed to a 2 centimeter lesion, then I may be thinking more of a regional local flap or skin grafting for treatment, and also the location. You want to see the quality of skin. Do they have a history of breast cancer and axillary node dissection with lymphedema? Is there already swelling to the hand? Also, the skin laxity. You want to pinch the skin to see how easily the skin can come and get approximated. That'll give you a good idea whether you can get this closed and do something in the office, or requiring a bigger operation, something that may require anesthetic in order to perform skin grafting or a local flap for the reconstruction. And always examine the lymph nodes. Very low risk of metastasis with a basal cell, but you still want to be in a good habit of examining the epitrochlear, which is right around the medial elbow location, as well as the axillary lymph node basin. If there is any abnormal lymph nodes, this may require additional testing with an FNA under ultrasound guidance that our interventional radiology department can do. So please do a lymph node exam when you're examining these patients. So there's 2 lesions here shown on the P1 area. So immediately in the P1 area, you would think a squamous cell, just based on that review series I demonstrated earlier. And then there's this other one on the back of the hand. You can see it's raised. There's some different coloration. It's it's asymmetrical. So you can have a different diagnosis. Is it a actinic keratosis? Is it benign? Is it malignant? Well, it turns out one of these are malignant and one is benign. And they have studied of how well we are able to predict what the lesions are with just visualization alone, and not being non-dermatologist. So this has been examined. This was a prospective study on the diagnosis of surgeons on skin tumors and skin lesions of the hand. And we're not very good. I mean, 65% is okay, but that was direct diagnosis, whether they thought it was benign, gave the benign diagnosis, and it turned out to be benign on histology versus malignant, and having the correct malignant diagnosis. Good thing is 90%, 92% of lesions that were thought to be benign turned out to be benign, which is pretty good. Only 3% were incorrect and were malignant, which is the worst case scenario, where we don't offer someone treatment and it ends up being malignant. So that happened 3% of the time, or would be in your practice. And then 65% of presumed malignant lesions were correctly identified as malignant. 11% were incorrect and were determined benign. So it just tells me that if someone's coming in with a skin lesion, that we're not very good of identifying this correctly, that biopsy should be our next treatment in our algorithm of further evaluation if they already haven't had one already. So this is just the chart breaking down. So this is where they predicted not 73% of benign lesions were correctly identified. Like I said, 92% of lesions that were thought to be benign were actually benign. They had the correct diagnosis spot on 73% of the time. And then here's where it got a little bit more scary with malignancy. They identified the correct type of malignancy only 54% of the time. There was a different malignancy 11% of the time, which upped their percentage to 65. But then like I said before, 11% were benign that they thought were malignant, and then the majority of these were pre-malignant. So not terrible. These can turn into malignancy and are warranted some type of treatment. But this goes to show you that we're not very good with our eyes telling us exactly what these skin lesions are, and that we should biopsy these to get a correct tissue diagnosis to guide our treatment. This is another table from that study. When they thought it was a squamous cell carcinoma, they were correct 75% of the time. 25% they were wrong, and there was these other etiologies, pre-malignant or the keratoacanthoma or basal cell. And then when they thought the lesion was presumed normal, histology showed SEC 58% of these specimens. So that is kind of scary when they thought it was presumed to be a keratoacanthoma. 20% it was a squamous cell. When they thought it was a pre-malignancy, 23% was squamous cell. So this really just tells us that we need to biopsy these skin lesions. And there it is. These are my rules for this. This is probably one of the most important slides of the talk. We're not very good. Hopefully I hit that nail multiple times with a hammer. Biopsy, biopsy, biopsy. And then for me, I don't like to shave biopsy. I like to get a correct depth, especially for pigmented lesions. I think that is a no-no. You should definitely do a punch biopsy if it's larger, or an incisional biopsy if it's a small lesion. That is, or an excisional biopsy, sorry, if it's a small lesion. Incisional biopsy is also good in order to get tissue. And whenever you do a punch biopsy or incisional biopsy, you want to include the junction of the normal skin adjacent to the abnormal skin and contain it both, so that the dermatologist can see what the normal skin looks like and then make a comparison to the area that you're concerned of with the malignancy. And these can be done by a punch or a scalpel for the incisional biopsy. And then it's real quick. You can do it in your office, a little lidocaine, punch or scalpel, and then a stitch with a chromic or a fast cut suture. And then you can get the appropriate diagnosis, which will dictate what your next treatment options will be. So there's this concept of surgical margin. Even when we see a skin lesion, there could be adjacent abnormalities, skin cells that we can't see. This is particularly true with melanoma in situ. Some of the melanocytes have already turned malignant, but have not produced pigmented coloration, and you can be very fooled. You can be fooled with excision, even with the correct margin, and have a positive margin. So for me, melanoma in situ and some areas that are more sensitive to bigger resections, I think that's a good indication for Mohs surgery, which we'll talk about later. Melanoma can also do this as well, just because of the melanocytes can produce no pigment, and we basically draw our margins from the pigmented edges, and we can be confused and fooled with these type of malignancies. Squamous cell, a little bit less likely, and basal cell, we're usually able to see the perimeter of the lesion and get good margins in a full excision. Obviously, the wider the margin, the better chance of clearance. And all you really need is negative margins. All these suggestions of 3 to 4 millimeters, they're just so that you have a better chance of obtaining that clear margin. With a Mohs surgery, they excise it until they have clear margins. It doesn't matter if it's a millimeter or 10 millimeters, you just want the cancer removed. And each of these have been studied and documented for each type of skin cancer, which we'll talk when we break these down individually. And then also consider finger function when you're trying to determine a margin. Sometimes you have to think anatomic pathways and obtain a 1 centimeter margin just because a 2 centimeter margin may indicate a ray amputation, which may be overkill for some of these malignancies. So what is a surgical margin? This is what happens when you send a tissue specimen down to pathology for permanent sections. They do a bread loafing technique where they get these specimen and they take slices and they examine these slices under the microscope. And with this type of tissue analysis, there could be areas where there is mist, where they're not making these bread loaves or cuts. So you don't see the true entire perimeter with a traditional analysis. But this is kind of the best of what we got for permanent sectioning, and this is how they are looking at all those specimens that we send to the lab. It's a bread loafing technique as opposed to a Mohs surgery. This has been named after Frederick Mohs, who's a dermatologist, and they used sequential excision and they use a topographic map. So what they do is they cut this out and they usually bevel around the edges, and they are able to flip the cancer and evaluate all 360 degrees around the entire perimeter of the lesion. They do this in their office. So if there's any area that comes to the margin, they're able to identify, they have the specimen marked, and they go back and remove just in that area. And then they redo the entire process, look at the entire wound margin, and if it's positive, they'll keep on cutting away until they are cancer free. So they claim a cure rate of 99% for primary tumors. So this is something to consider if you have a recurrent tumor or aggressive subtype. Think about a Mohs referral. I usually do this for melanoma in situ if I'm worried about margins, or in the finger nail bed region with squamous cells, where they can ensure there's complete removal and try to preserve fingertip length. But these are the indications. These are commonly asked on board examinations. So recurrent tumors, cosmetically sensitive areas, but the face, more morpheaform or a aggressive subtype of basal cell. If you can't see the tumor margins because of scar, that'll be an indication. Anything with perineural invasion, and then a other type of skin cancer, dermatofibrosarcoma or dermatofibrosarcoma protuberans. That's also an indication for Mohs referral. So this is how I like to do the tumor excision. I use my loops when I'm marking these, and I see the lesion, and also I use the tip of a felt marking pen to see where there is induration. I consider that part of the malignancy, and you can really feel a step off between supple skin and the areas of the tumor. So I first mark that. I do wipe the area clean with alcohol because I don't like to wipe alcohol after marking a lesion because it'll smear the marker everywhere. So then I draw the entire margin, whether it's 4 millimeters or 6 millimeters or larger, depending on the cancer we're dealing with, and mark that out completely. Then I inject with local anesthetic. Remember, I already prepped with alcohol before I marked my margins, and then I will tumesce the area with local anesthetic if I'm doing this in the office. If we're doing anesthesia and you want to use Esmark, there is some theoretical risk if you are using Esmark that you may spread the tumor cells within the lymphatics. I really try to be mindful with this. I'll probably, and most likely, if I'm using it or doing this in the operating room, I will use an Esmark. I'll do it very lightly in the area of the cancer, then wrap more tightly and more proximally in order to see adequately to get a good, clean surgical dissection and good resection. I never want to compromise my visualization, and the tourniquet is our best friend. Esmark definitely helps that. And I try not to manipulate the lesion. Like I said, if it's on the fingers, I'll wrap from the hand and go more proximal. If it's on the hand, it'll just be very loose around the hand and then tighten as I go to the forearm and elbow region to get a good sanguination of the limb. Orientation, so you try to design your excision longitudinally. That is in case you have a permanent or a positive margin, so you can have a re-excision. If you're having a large area that you don't think you can close primarily, don't use an ellipse. I would just mark the lesion in its entire perimeter, add the margins and excise the tumor first, and then plan for my reconstruction, whether it's a skin graft or a local flap after the cancer resection. I tend to incise the entire perimeter, full thickness, so through the epidermis and dermis into the subcutaneous tissue about midway. I think this is a good starting indication for removal of most of these skin cancers, except for melanoma. And then I resect in this area. It's usually above the veins. If the area is deep and I feel that the margin is close, an extra pearl is to take an extra swath of deeper tissue and label this as true deep margin. I have seen on pathology where the cancer comes to the surgical margin. Then if you add this extra layer of tissue and that's negative, then you know that you got the entire cancer out and you don't need to do a re-excision if that true deep margin is negative. So that's helped me out a bunch of times to get that extra tissue. So remember that when you're doing these biopsies. You should send all these lesions to pathology. Like I said earlier, we're not very good at correctly identifying these skin lesions. If I am going to do a primary closure with an ellipse, I don't mark the lesion because if there's a positive margin, what we do is we excise the entire scar and reclose. So I don't waste the time to mark the lesion. If it's going to be a local flap or skin grafting, I will mark the lesion. I like silk. It ties knots well, it holds, and usually do 2 stitches for corrected orientation, however you want to label them. So moving into skin cancer types, we're going to go over several of these. By far, the most common of the hand is squamous cell carcinoma. They have various presentation. They can be very exophytic and look very aggressive, like that finger on the bottom right corner, or they can be dry and scaly on the top picture there on the right. Some things that the patients may say is that they've crust over and bleed, or they pick at them, they heal, then they'll recur. Those are all terms that should make you suspicious for a malignancy. We talked about the sun exposure and the Fitzpatrick types 1 through 3 risk factor for developing these, any type of radiation treatment. There are things called marginal ulcers or chronic wounds that develop squamous cell carcinomas. These are more aggressive, have a higher risk of metastasis and a worse prognosis. Anyone that is immunosuppressed, especially transplant patients, higher risk of developing squamous cell carcinomas, about 65 times greater than the general population. And there are some genetic abnormalities, xeroderma pigmentosa, that makes you prone to skin cancers as the cell repair mechanism is hindered. So there's also some other benign lesions that are seen here. Here are some scaly lesions. These are actinic keratosis. This is considered a pre-malignant lesion. About 10 to 20% of these will transform to malignancies, so they do require treatment. About 80% of all squamous cells originally at one point were actinic keratosis. Bowen's disease is squamous cell carcinoma in situ. This can turn into malignant invasive squamous cell with time, about 10%. Same as leukoplakia of the tongue, about 15% chance of transforming into malignancy. And then here is that aggressive lesion that can turn into a squamous cell, 16.7% keratoacanthoma. This is large papule with central ulceration and keratinizing material centrally. The history is they come on rapidly and then they involute, and it can take up to a full year. But like I said, 16% are actual squamous cells, so most of the time the treatment is excision to ensure they don't turn into malignancy. These occur on sun-exposed regions. Remember, that's a high risk factor. So we're talking about the head, neck, arms, and then mainly the dorsum of the forearm and particularly the back of the hand. We talked about the different range of presentation from slow-growing hyperkeratotic lesions to large exophytic tumors. They can be smooth in appearance, or they can be wart-like or even ulcerative. They often itch and bleed easily, and they do have the capacity to metastasize via lymphatics or through the blood. The risk is small, though, for these, and those are usually the large tumors that have the chance of spreading. So we were talking about surgical margins earlier. The treatment for squamous cells, so if it's less than 2 centimeters, remember, measure the lesion. 4 millimeter margin should give you about a greater 95% chance of cure, which means a clear margin. If it's greater than 2 centimeters, then they recommend a 6 millimeter margin just to ensure that you have a clear margin and don't have to do repeat surgery. And then you should include some of the subcutaneous fats. Like I said, I go mid subcutaneous tissue level, as 30% will invade this deeper layer. And always with the squamous cells, if I do feel like it's penetrating the subcutaneous tissue, I would send a separate specimen as true deep margin after you resect the cancer and you have healthy adipose tissue. I will include some of that to ensure that I have a clear margin on the deep surface. These can be quite large. For large malignancies like this, may require skin grafts, local flaps, or free flaps. We will talk about this more in the case presentation with our in-person talk for this subject. Usually don't want to do a distant pedicle at the same time. If you have an incomplete resection, now you may see the new anatomic area, so a groin flap will be a bad idea to do at the same surgical setting as resection of this large mass. There are some non-surgical treatments for pre-malignant lesions. So we're talking about the actinic keratosis. You can try topical 5-FU. There is cryotherapy with freezing as treatment. Usually, if you do these non-excisional treatments, if you do 2 rounds and the lesion's still there, you better get a biopsy or consider some other treatment modality because you may be mistaken for a pre-malignancy with a true actual squamous cell. And then if there are non-surgical candidates, you can consider chemotherapy and radiation as non-surgical treatments, but surgery is the mainstay of treatment for these non-melanocytic skin cancers. We talked about spread. It's about 2 to 7%. These are for usually the larger or definitely a Merjolin's ulcer. They have a higher risk of spreading. If you do have metastases, your survival drops significantly to about 30 to 40% at 5 years. So they don't metastasize often, but when they do, it's very aggressive and it really decreases the prognosis of life expectancy. For anyone that you do feel a large node, get an FNA. They can do this under ultrasound. If that turns out to be positive for metastasis, then you should consider a surgical oncology consult if you don't do this regularly and perform an axillary lymph node dissection for any positive nodes. A variant here is a subungual SCC. These are not common, but they do occur. If it does involve the bone, this may require a DIP in the finger or IP, a disarticulation if the bone is involved. These are the ones I typically refer to most, especially for squamous cell in situ on the nail fold or germinal matrix. And if there is no bone involvement, they can get a clear margin and they can have cure rates up to 94% without performing the amputation. This may require skin graft reconstruction afterward or a adipofascial turnover flap if there's bone exposed and skin grafting. And I have a couple of these coming up later in the month for treatment. So after you get your excision, you do your reconstruction, you got clear margins. What do you do next? They do need serial examinations of their skin. One study showed at 5 years, if you had one primary skin cancer, you have a 30 to 40% chance within 5 years of developing a new skin cancer. So they do need to have the site examined every 3 to 6 months for 2 years, and then it's either twice a year, yearly for the next 3, and then once a year after 5. I typically see them once, make sure I have clear margins, they're healing well, and then I refer them to dermatology for full body skin examination, and then they can check this site. If there's no dermatologist around, then you should stick with this examination pattern. and counsel them. And I ensure that they have a dermatologist before releasing them. If you're in an area without dermatology, then you're kind of on the hook to see them, every 3 months to 6 months for the first 2 years. You need to do that. You can't abandon your patient. So you need to ensure that they have appropriate follow-up after treatment of any of these malignancies. I always tell them sun protection, SPF 30 or greater, and going higher than that really hasn't shown to be much more protective, but it does get more expensive. And then a wide brim hat, clothing with SPF, all these things are good measures to protect the skin to prevent further damage. So jumping gears a little bit is basal cell. This is the second most common malignancy of the hand. They occur more frequently on the back of the hand than the digits themselves. Once again, risk factors are as we get older, as well as light-skinned, and they can have this pearly border and some superficial telangiectasias within the lesions themselves. These also have various presentations. They can look pretty malignant like this. If I saw this lesion here, I would think it was either a keratoacanthoma or a squamous cell cancer variant. So they can look pretty horrific as well. With all these, you'll want to get a biopsy to ensure you have proper diagnosis, and then do the treatment with the recommended margins. These metastasize way less, almost rare, less than 0.1% metastasize. So there are some other treatment modalities other than excision for the basal cell because there's such a less risk of spreading. But they will continue to grow without treatment. There are several subtypes. There's nodular, which is the majority. Those are the ones you saw previously with the pearly border. You can see here, this is the nodular type of basal cell. There could be superficial spreading, which you see here, which grows pretty rapidly around the periphery. There's micronodular, that's more based on the pathology. And then these are more aggressive. There's infiltrative and morpheoform. Morpheoform is more scar-like. These are very hard to get good margins because the tissue blends in very closely with the malignancy. They are the most aggressive, and these are the ones that I will typically send the Mohs surgery if we have that subtype on our biopsy. So with any type of reconstruction, we want to get a cure of tumor. That means clear margins and preserve function and cosmesis. Some of these can be treated medically and not with surgical excision. There's also some destructive pathways, and then finally surgical excision. That's what I typically offer most of my patients as we are hand surgeons. So there are topical creams. There's Aldera and 5FU. This works well with a superficial spreading because they grow more on the top layer of the epidermis, where the cream can interact with these malignant cells. You never get a true margin when you do this, so you can treat it, and if the lesion is clear and there's no hyperkeratosis and the lesion's gone completely, you assume it's adequately treated. You can do radiotherapy for tumors up to 2 centimeters in thickness with a great 92% cure. Once again, you don't have margins. You don't know if it's fully treated, and you want to avoid this in patients with a wart-like cancer or certain genetic conditions, and it can cause osteitis and skin necrosis, and actually be more prone to skin cancers down the road. So I typically don't offer radiotherapy as a primary treatment option for any of my patients, but it has been described. Cryotherapy, this is freezing. These are for small, skin malignancies. You can do this until there's a rim of whiteness around the area. We do this commonly at the VA hospital. Can cause permanent hypopigmentation, so do counsel your patients on that, as well as some swelling to the treated area. If you already have a recurrent basal cell or morpheoform, which we discussed was more aggressive and more scar-like, then this is contraindicated. There's CO2 laser, once again, unable to evaluate surgical margins. And then there's IPL or blue light treatment. They give a light activated drug over the skin. The oxygen-free radicals destroy the cells with application of the blue light. The thinking is that these are more metabolically active, so they take up the photosensitizing drugs more quickly, and then the blue light causes the free radicals to destroy them. So very low risk lesions, basal cell superficial spreading. This is a treatment modality, the IPL or the blue light treatment. But for me, the majority of these we're surgeons. If they have a basal cell, I'm going to offer excision. A 4 millimeter margin should give you a great cure rate. Once again, mid subcutaneous tissue depth. And if it's less than 2 centimeters, you have over a 95% chance of getting completely excised. So, some people refer all these people to Mohs who claim 99% cure rates. I mean, with 95, when I do these, it's about 98%. I think I'm very comfortable doing this. And once you get skilled at this and see a lot of these in your practice, I think you'll be comfortable treating them as well. So if they're larger than 2 centimeters, you can consider Mohs. I'll still offer them excision. The one caveat is morpheoform. I may consider a Mohs referral at that time for that variant. But otherwise, I'm typically excising these either in the office or in the operating room. So adjuvant treatment, this is for both basal cell and squamous cell. If you have perineural invasion, you can consider and at least get them seen by radiation oncology for possible treatment. If you have positive margins, you can offer re-excision. If it's an area where you can't perform re-excision, then you should offer radiation therapy. And then for head and neck patients, they can get postoperative radiation after the lymph node or the neck dissection. There are some interesting chemotherapy options available, especially for basal cell, where there's hundreds of people or hundred of lesions, and some people with genetic pathways. It follows the hedgehog pathway inhibitor, and those are the ones where there's too many lesions or have had all surgery and radiation and have recurrence. There are some things you can try, and this will be with the referral to medical oncology for consideration. So if you didn't get a clear margin, what to do. So this is a study from the VA hospital out in Utah where they did shave biopsies and they looked at 233 shave biopsies. And what they wanted to see, if there was a positive margin, what would happen on a subsequent excisional biopsy. Now, was the repeat biopsy, did it show cancer or was it completely scar tissue? Because sometimes when you do an excision or a shave, you do get the last cancer cell and then it won't turn out to be any additional cancer on your positive margin. So what they found out that for 42% of re-excision, so these are shave biopsy with positive margins, 42% had no negative tumor, which means about 58% did have residual tumor in the specimen. For SEC, this is interesting, 73%. So, over 2/3 were negative for tumor, with the remaining having residual tumor. So even with 20% or so having residual tumor, the recommendation is still, if you have a positive margin, to do a re-excision. Other option would be to serially examine the patient. I wouldn't have that fall on dermatology. If you're going to treat any of these non-operatively with a positive margin, you do need to see them every 3 months to make sure they don't have a early recurrence. If they do, then offer a full excision once again. We looked at our data here at Carillion. This is a project I did with Dr. Tramer. We looked at all non-melanoma skin cancers who had an excision, a positive margin, and then were treated with a second surgery within 6 months. We did a 5-year period and found 63 patients. And when we did this, so this is a little bit different. These were not shave biopsies. These were primary excisions with closure, and then had the pathology show positive margin, and they went back on a second excision. And on a second excision, roughly 56% showed skin cancer for BCC and 46% for SEC, for residual cancer. So nearly about 50% had residual cancer. So that is further evidence that if you do have a positive biopsy, that you should offer the patient re-excision, but do let them know that 50% of the time they will just show scar and not cancer. And what's interestingly, when we went back for the repeat excision, 15%, and these were mainly in the head and neck, had a second positive margin. So in our conclusion for the head and neck region, if you've had one positive margin and did one re-excision, if there's still a positive margin, you should probably refer them to a Mohs surgeon to ensure complete removal. And this is just our number in a grammatical or a chart-like form. So second excision, present of residual tumor for basal cell 56 and for squamous cell 45. And this is for a second excision for a positive margin. Total for basal cell was 12%. Had a positive margin after 2 excisions, and for squamous cell 16, majority being excised, and the majority of these positive on repeat re-excision was from the head and neck region. So that's some from data from here from all of us. Now changing gears, we're going to melanoma. As you can see, this is a pigmented lesion on the finger involving the nail fold, and the finger pulp. So these are a lot more aggressive and require a different type of treatment, a whole different category of treatment in thinking about melanoma versus the basal cell and squamous cell. So what is a nevus? A nevus is a mole. It's a benign proliferation of the melanocyte, which is a nevus cell. These cells are clustered, as you can see in this histologic slide. They produce pigment, melan. There can be some melanocytes that do not produce pigment, and that can be confusing for the melanoma in situ or even melanoma. And I have been burned and had positive margins because of that. And these can be acquired, meaning that they develop on the body after 6 months, or some people are born with moles, which is a congenital variant. And each of these type of nevi can be common or atypical. So what is an acquired mole? I'm sure most of us have moles on our bodies. These are acquired after 6 months of age. They can increase in size and number as you get older, and then they slowly regress. There is different stages. There can be junctional, which are flat, well circumscribed, uniform in color, and all of them should be less than 6 millimeters, which is the head of a racer head. If they're compound, meaning that they're a little bit elevated from the tissue, that means that the melanocytes have penetrated a little bit more deeply into the dermis. That gives them the elevated appearance. There could be ones that are intradermal only, where the melanocytes are in the dermis, so the pigment is not seen on the epidermis, so they are more of a nude color and non-pigmented. And then anything on the palmar plantar skin are acral, and those could be acquired moles. These are normal, nothing to do with them unless they start to change or do not have these benign characteristics. So congenital nevus, this is real big in plastic surgery literature. These are ones that are present at birth. They can have hair on them. They are typically larger than acquired nevus, so they're greater than 6 millimeters. They grow proportionally with a child. And there's different classification. There's small, there's medium, and there's giant. There's different criteria and different staging for giant nevi. Some people say 10 centimeters, some people say 20. Some people say if you can't fully excise it in one surgical setting and get a primary closure, then that's considered giant nevi. And why that's important, because there is a risk to progression to melanoma of 0 to 9%. It's probably around 4% for a very large giant congenital nevi. And the majority of the ones that are going to turn malignant will do so by puberty. So these are usually the child that are coming with their parents with these large nevi, and you have to counsel on what is the next step to do. Given that there's a slight increased risk of melanoma, most of the parents will want these removed from their child. And I think that's a reasonable treatment. So everyone's heard of the ABCDs of melanoma. So you want to look for asymmetry. You can see here very asymmetrical on this lesion. Uneven borders, irregular shape. Those are things that should clue you in that you should biopsy these. Different coloration, should be uniform in color. Diameter, we talked about the 6 millimeters or the head of a eraser. And then evolving, meaning that if there was something that was there and it's starting to change, even if it doesn't hit any of these other criteria, a changing mole is one that is suspicious and should be biopsied. And these are ones that need to be followed by the dermatologist. So here are two different pigmented lesions. This is a benign blue nevus. You can see it looks bad, but it's uniform in color, and you can draw a line and compare one side to the other, and they're symmetrical. So this will probably a biopsy, but it has benign characteristics versus asymmetrical. You can initially see this one may be less aggressive, but if you draw a line, you can see that this side is a lot larger than the other. There's also some coloration within it, and then this ended up being a thin melanoma. So these are all clues to detect if you're worried about any skin lesion, especially anything with pigment, anything that is abnormal, it's better safe to biopsy and get a tissue diagnosis because these can be fatal. They can spread rapidly, and these are a lot more dangerous than the basal cells and squamous cells that we previously talked about. So unfortunately, this is also increasing over the past 50 years. Incidence about 15 per 100,000 and 4% of all types of cancers. This is old data from over 10 years ago, about 76,000 cases new each year for the US. Once again, radiation, UVB, definitely increase your risk of melanoma, and these are usually in your, your early years, your childhood and your teenage years. There can be familial, so ask about family history. If you have 2 first-degree or 3 of any relatives, it does increase your risk 2 to 8 times the general population, and these tend to occur at a younger age. So do get a family history when you're talking about pigmented lesions. These are some of the other risk factors for melanoma. Greater than 50 years just from prior sun exposure. Prior melanoma increases your risk. We talked about the Fitzpatrick types, one and two, and three. Tends to be more males than females, and definitely for Caucasians greater than blacks or African Americans. And then there's some other predisposing conditions. Atypical mole syndrome, they have many moles, over 100. There's atypia. There's from a gene mutation. They're definitely at higher risk of having melanoma. Even if you have a biopsy that shows atypical nevus, so an atypical nevus shows some early malignant changes, but not classified as malignant melanoma, they have a 6 to 10% chance of risk of development invasive melanoma and do require full removal and negative margins. And we talked about congenital nevus, that it's probably around 4.5%. And then if you even have normal moles, but the number is greater than 50, it does increase your risk of having a melanoma at some point in your life. This is from the National Comprehensive Cancer Network. These are all the risk factors for melanoma. We mentioned the majority of these. Also, tanning bed exposure is also a risk factor, and some of these other immunosuppression that we talked about for squamous cell. So for types of melanoma, there's melanoma in situ. It's definitely the best type to have if you're going to get it. In situ meaning contained within the epidermis, therefore no chance of spread. Superficial spreading, which spreads radially rather than vertically, so less chance of lymphatic spread. Nodular lentigo maligna, which is a melanoma situ to superficial spreading variant that is also low grade, and then anything on the palm and soles of the hand, the acral lentiginous, and also the subungual variant in that category. So melanoma situ, this is the early form of melanoma. It's completely confined into the epithelial layer only. It does not break the basal layer, therefore there's no risk of metastasis. This is a favorable tumor type that we mentioned, the lentigo maligna or Hutchinson freckle that's occur on the face, most notably over the cheek or the surface of the forearm. This is a tan flat macule that's been there for long, many years, 1 to 2 decades with some radial growth. There could be some harbor invasive melanoma, so these do require treatment. And then any appearance of raised melanoma that indicates that they have turned from in situ to invasive and require aggressive treatment. So this is a melanoma situ. Even the surrounding skin that does not have pigment can harbor atypical melanocytes. So I have been fooled with positive margins. You could consider a referral to Mohs surgery. And what they do is they excise it, they send it out, get a fast turnover within a day, and then continue with resection until it's completely gone. The recommended margins for melanoma in situ is 5 millimeters. There has been a large retrospective study saying that 8 millimeters has a higher risk of complete cure. So if you have an area where you can still get primary closure, you may want to consider 8 millimeters to start out with melanoma in situ to ensure that you have a complete negative margin and avoid subsequent re-excisions. Remember to orientate your ellipse longitudinally. You can also do a temporary closure with Integra or allograft if you're planning on skin grafting for melanoma in situ to ensure correct margins. If you're going to consider a graft or flap, I highly recommend getting a clear margin. So your Mohs surgeon first, because I have been fooled in the past. This is one where it's very hard to get a clear margin just because some of these cells do not produce melanin, and you can't see the pigment in the surrounding tissue, and you can't have positive margins in normal appearance skin. So that's when I probably do a slow Mohs referral. Superficial spreading is the most common variant, most likely from a pre-existing nevus. They have variable color, asymmetry. They usually grow radially than vertical, so less risk of being very deep. Remember, for melanoma, we'll talk about the depth is the prognostic indicator for treatment and prognosis. There's nodular, which means are raised. These are more aggressive because they don't grow radially, they grow more vertically, so higher chance of becoming deeper. A thicker melanoma has a higher tendency to spread. These have early metastatic potential, and they can also be amelanotic or clear, which may delay the evaluation and diagnosis, and have a large, thicker melanoma, which can be more deadly and higher risk of spread. We talked about this before. This is the lentigo maligna or Hutchinson freckle. This is usually over many years. I see this on the forums a lot, and then they all of a sudden become nodular. When they become nodular, that indicates a more vertical growth. It may turn into a malignancy, and that requires biopsy and treatment, and Mohs surgery is a good treatment for these. So acronal litiginous, so 2 to 8% in Caucasians. This is on the palm or sole of the hands or feet. This is the #1 type in non-Caucasians. These are in the glabrous skin. They're usually flat and can have irregular borders. They have different coloration throughout it. And they have once they transition to a vertical growth phase, it definitely increases the risk of metastasis. And these tend to be more aggressive as well, just like the nodular melanomas. These subungual melanoma arise in the nail matrix. They can be seen with longitudinal melanocii. This can be mistaken for a subungual hematoma or someone saying they hit their finger. So anything that's been present for more than 2 months requires, we're talking about for pigment on the nail plates. Anything present more than 2 months should require a nail plate removal and biopsy. If it's an elderly patient, you should consider biopsy if there's no clear history of trauma. If it's been changing over time or some nail deformity, and anything involving the nail fold or eponychial area does require biopsy. That's the Hutchinson sign, and that's indication that this is a malignancy and not from trauma. So anything along the lateral nail fold or eponychial area, you should have a high suspicion for melanoma and warrant a biopsy and recommendation for your patient. And lastly, there's this desmoplastic. This is the least common subtype, prominent for perineal invasion and for spread. These are more known to be thicker melanomas, but do, for whatever reason, have a more favorable prognosis with this subtype. So biopsy, anything that you perform, if it's small enough, you can do an excisional biopsy for 1 to 2 millimeters in order to get some of that normal appearing skin adjacent to the pigmented area enclosure. But for the majority of these, I do a punch biopsy or incisional biopsy to get a full thickness biopsy down to the subcutaneous fat in order to appropriately stage these melanomas. I do not think you should ever do a shave biopsy for a melanoma. If you don't get the full thickness, you can have a thin melanoma, which requires specific treatment. And then when you do the excision, the melanoma is deeper, and they may not have gotten a lymph node biopsy, which they're required. So please, for staging purposes for a pigmented lesion, do a punch or incisional biopsy for these. And that's just showing no shape biopsies for me for pigmented lesions. So staging, it's all about the depth. There's a Breslow depth. Tumor thickness is the most important prognostic variable for melanoma and is the best predictor of survival. So if you have a lesion that is ulcerative, that upstages it to the next T substage, and the mitotic rate greater than 1 per millimeter squared has a worse disease-specific survival. So those are things that we will look for on the histology is ulceration and a high mitotic rate. Those are worse prognostic indicators. The number of lymph nodes replaces the lymph node size for staging. And then there's been a subcategorization of stage 4. It's based on the anatomic site of the metastasis and if they have an elevated LDH on their blood work. So here is the Breslow depth. Basically, they measured the depth of the melanoma in millimeters. Anything greater than 1 millimeter is considered a thick melanoma and upgrades the T size. And as you can see, as your thickness goes, the higher chance of malignancy and spread, or not malignancy, but metastasis. As you get into those lymphatics and blood vessels, the higher risk these tumor cells can spread. So Breslow depth is the most important thing to occur. And if you did a shave biopsy, you can go right through the tumor layer. So this is why I always do a full thickness punch biopsy to ensure that we get the correct Breslow depth so we can go give the patient the best chance of cure and the appropriate surgery after staging. So this is the JCC melanoma staging classification. I haven't seen this been asked on a test. I guess it would be fair game. You're really looking for T1 is less than 1 millimeter. Anything greater than 1 millimeter is a larger, thicker melanoma, T2 or greater. And then if it's 1 to 2, 3 lymph nodes, this bumps you up to stage 3 disease down here with involvement of the lymph nodes. And then here is where the subcategorization of metastatic to the skin or to the lung or to other viscera for stage 4. So what is the risk of metastasis? We talked about that for squamous cell, very rare for basal cell. So for a thin melanoma, so anything less than 0.75 millimeters, the risk is less than 2%. So therefore, a sentinel lymph node biopsy is not usually recommended for a very thin melanoma. If you have one that's 0.76 to 1.49, there's a 10% risk of regional metastasis, and a sentinel lymph node biopsy is usually recommended. And if you have greater than 1.5 up to 4, there's a 20% risk of regional metastasis, and anything greater than 4 is about a 35% chance of regional metastasis. So it really seems to change from a thin melanoma at 0.75 to 0.76, the increased risk of metastasis, which prompts a referral to surgical oncology for me for consideration of a sentinel lymph node biopsy. So prognosis, once again, we're talking about Breslow depth, so the depth of the melanoma. Melanoma in situ should be 100% because there's very little risk that it can spread as it's confined to the epithelium only. If it's less than 1 millimeter, once again, thin stage T1 melanoma, 95 to 100% at 5 years. 1 to 2, 80 to 96, 2 to 4, 60 to 75, then greater than 4 millimeters, high risk of spread, 50% survival of 5 years, the worst prognosis for those large, very deep melanomas. So what if you do confirm a melanoma, what should you do for your workup? So for stages 1 and 2, so that's without lymphatic spread. You usually don't have to do any advanced imaging like CTs or PET-CTs unless they develop specific symptoms. Once again, this is after your staging based on your Breslow depth and whether or not you did a sentinel lymph node biopsy. If the sentinel lymph node biopsy is negative, then they'll be in stage 1 or 2, depending on the melanoma depth. If it is stage 3, then you can consider further imaging. Usually CT, you can get CT, PET-CT as well to see if there's any other malignancy. Because once you have lymphatic spread, theoretically the cat's out of the bag. It can spread anywhere in the body. So I think most people would involve a whole body PET-CT to ensure there's no additional metastasis further than the lymph nodes. But usually surgical oncology is involved, at least for me, for anything that involves lymph node dissection, and they make the determination of what additional imaging modalities they want to get for these aggressive and stage 3 melanomas. So here's another important slide. So for tumor thickness, once again, this is on the Breslow scale. Recommended margins for in situ, we talked about 0.5 to 1. 8 millimeters are probably a safe go-to for this to ensure adequate margins in a clearing first excision. If it's less than 1 millimeter, 1 centimeter margin is all you need. If it's 1 to 2, the recommendation is 1 to 2. Most surgical oncologists, if it's greater than 1, will jump up to the 2 centimeter category. But I would consider the anatomic area. If it's on near the eyelid, ear, or on the finger, it may lean closer to 1 centimeter versus 2. So just consider the anatomic area you're treating. If it's on the leg or forearm, then and you have more room and more soft tissue laxity, I would be more aggressive and do the 2 centimeter. Anything greater than 2 requires 2 centimeter margins for excision. So how far do you dissect? For these, you have to go deeper. You can't go mid-subcutaneous tissue. You should resect all the subcutaneous fat for treating melanoma. You should go down, but not include the fascia. Actually, removing the fascia increases the risk for metastatic disease somehow. So it's not recommended that you remove the fascia. So that means the peritoneal level for the dorsum of the hand. And for the different treatment for subungual melanoma, amputation is recommended to the joint space proximal to the lesion. Mainly, if you need to go proximal to the joint, it's mainly because you want to get a clear skin margin. So you want to get your 1 centimeter margin, and that's typically what I look for when I plan these for excision. So this is for the thumb or for the digit. For the digit, you want to make sure whatever the Breslow depth is, you get your 1 to 2 centimeter margin based on your Breslow depth, and then whatever you can do for reconstruction. If you get your 1 centimeter depth, I have no problem going through the DIP joint and then creating a volar skin flap. So the amount of tissue you leave is going to dictate the level of amputation. So you definitely want to go to the area. And for the thumb, I try to preserve the IP joint. That usually gives them a sufficient thumb as long as they have enough skin for closure. Even if they don't have enough skin, I may perform an IP disarticulation and then do some type of reconstruction, FDMA flap, or some other type of Moberg for reconstruction if needed to ensure I get good margins as well as a functional thumb after the amputation. So for reconstruction, skin grafting is more common because you're removing a lot more tissue with the melanoma. You can't consider local flaps for the forearm and hand, or forearm and arm and leg. I usually perform in the same setting for invasive melanoma. I usually don't have problems with margins because the margins are so large, 1 to 2 centimeters, that I feel comfortable to perform the reconstruction at the same setting. But I do tend to delay them for melanoma in situ because I have been burned in the past with the positive margins for this, or perform a slow-mos beforehand, ensure that we have adequate margins, then perform the reconstruction. And for me, in the arms and legs, if I can avoid a skin graft, I try to do that. I feel like it's a quicker recovery. This is a brief reconstructive modality, a modified keystone flap that I'll go over that is very helpful for the forearms and legs for reconstruction of the melanoma defects. The reason why I don't like skin grafting is that the defects are a lot deeper. They go through the skin and subcutaneous fat down to the fascia. So if someone that has a large subcutaneous tissue layer, the skin grafting can be very hard to perform due to the concavity of the wound. So a modified keystone flap can help with reconstruction. So I'll be happy to send this to anyone. This is the real keystone flap where you perform your defect. You perform this large flap that you make all the way the incisions, and you close the most proximal and distal portions in a V to Y manner that creates central redundancy, so you can remove this. You can move this tissue laterally or medially for closure. This does require you have intact perforators into this island, so you do have to know your perforator anatomy to do these adequately if you're going to do a true keystone flap. And then here's the modification. If you're not sure about the anatomy, you can leave this little area of skin. It's usually the width of the defect, and you make your incision through the skin and release the fascia. It's by releasing the fascia that allows this mobility of the flap. So you do advance it V to Y in this manner. This is just showing that they did cut the fascia but left the skin in order to mobilize this tissue to advance into the defect and close it in this type of particular pattern. So this is a melanoma case I performed on the lower extremity. You can imagine this is a form, if you may. So that's excision. You can see its full thickness of all fat down to the fascial layer. And then I did a modified keystone flap, so you can still have a flap length of width of 1:1 here, and then advance these both proximally and distally in a V to Y manner. This is me outlining the popliteal crease, as I didn't want to perform a longitudinal scar in this area to prevent and limit the chance of contracture. So that's with closure, and you excise this advanced tissue of redundancy, and then you get your final scar configuration. You can see we came right to the popliteal crease, but not cross over. And you can see a nice flap, and that's a lot quicker recovery than trying to do a skin graft in that location. Another case, melanoma, excised, immediate reconstruction. This one, there was some more soft tissue laxity. We were able to do a rotational flap and close that. So you can do different local flaps. Definitely a better contour to it, better recovery than doing skin grafting. There's nothing wrong with skin grafting, just different ways to reconstruct these wounds for different patients. So you can see there, and then here's the back cut and advancement on the medial aspect of the arm. So for the lymph nodes, if your Brazil death is very thick, you will want to do assessment of the lymph nodes. If you don't do sentinel lymph node biopsies or dissections frequently, referral to surgical oncology is a must. So there is no survival benefit, I'll just throw this out there, of a lymph node dissection if you don't have palpable nodes. It's really for regional control, and then it can be palliative for patients with thick melanomas. So what is a sentinel lymph node biopsy? The idea is to find the sentinel node, or the first node draining a tumor or a particular body of the finger or the region. And this represents the metastatic involvement of lymph node basin. Basically, if there's a spot on your body, it's going to drain to this lymph node first. And this is a staging procedure. It is not therapeutic. This is done by performing injecting a radiocolloid into the skin. This is done by interventional radiology, and this is picked up by a gamma probe. You can also inject blue dye at your melanoma, and then also look for that in the axilla. They usually do a radiograph demonstrating where the radiocolloid is being taken up, so you have an idea. And then you go and try to sample this node by the gamma probe. You remove that. Anything that has a high count, you are removed until it falls down to less than 10% baseline. And also you try to look for lymph nodes that are stained blue, or these are most likely to be draining that area of the body. Because if you sample a lymph node, you want to make sure that you're sampling the correct one. The thinking is that if you sample the sentinel lymph node, then this is the most likely lymph node that the melanoma would metastasize to, and leaving the remaining intact. So who should get a sentinel lymph node biopsy? So anyone with a intermediate thickness melanoma, 1 to 4 millimeter, should get a sentinel lymph node biopsy. And also anyone with a subungual melanoma should also get a sentinel lymph node biopsy. Anything greater than 4 may improve staging or regional disease control. You may offer a complete lymphadenectomy, as they have a high risk of having metastasis. And then if it's less than 1 millimeter, there are some caveats. So the current recommendations, this is from a multi-center selective completion lymphadenectomy trial, MSLT1. So the current recommendations for a sentinel lymph node biopsy is if you have a tumor that is greater than 0.76 millimeters thick, with ulceration or a high mitotic rate. Remember, we told those upstage the disease, those are more aggressive. So greater than 0.76 with ulceration or a high mitotic rate, sentinel lymph node biopsy. Any patient with greater than 1 millimeter, also sentinel lymph node biopsy. If your sentinel lymph node biopsy is negative and they have no palpable disease, there is no role for a completion lymph node dissection. So they wanted to, in the second trial, what is the value if you do have a positive sentinel lymph node? What's the benefit of doing a completion lymph node dissection? That's the CLND. So based on this study, they wanted to evaluate the usefulness of a completion lymph node dissection because this significantly increases the rate of lymphedema in that extremity. So they want to compare this by performance surgery to frequent ultrasounds of the axilla and a dissection only if clinically evident node recurrence is seen or pathological nodes are seen on ultrasound. And their primary endpoint was melanoma-specific survival. So they're just looking at survival in this MSLT2 trial. And guess what? A completion lymph node dissection was not associated with increased melanoma-specific survival. So I'll repeat that again. It did not increase survival. It did increase disease-free survival in the completion group, but they did have a higher rate of lymphedema, 24% versus 6%. And the ones that they did do a completion, they did find occult metastasis in about 8 to 10% of the patients. So this would have been 8 to 10% that had a sentinel lymph node biopsy that had additional metastases. So it does show that the sentinel lymph node biopsy is pretty adequate for staging purposes. And it also reduced the rate of regional node recurrence by 70%. So it does contribute to local disease control, local disease reduction of recurrence, but it does not increase survival. So that's something to counsel the patient. That's usually what Dr. Limbazi talks to them about. He always recommends completion just because of regional control, but it really does not increase their survival for melanoma by doing the completion lymph node dissection, and it significantly increases their risk of lymphedema. So there's a bunch of adjuvant therapies. None are routinely recommended as none of them are great. There are some usage against subclinical micrometastases. There's interferon, which has horrible side effects. Radiation therapy is also very not good. The chemotherapy is for palliative cases. And the most research is done on immunotherapy. There are clinical trials with vaccines, monoclonal antibodies. I just read that based on the new mRNA technology, they are developing some immunotherapy that is very promising for treatment of melanoma. So these are adjuvant treatments to your melanoma. These are for mainly for stage 3 disease and be involved with a medical oncologist. Radiotherapy, this is mainly for the axilla. If more than 3 lymph nodes are involved, you can refer them to radiation oncology. If there's any lymph node larger than 3 centimeters or recurrent nodal disease, you can consider radiation to this area. Probably have a high risk of lymphedema with excision and radiation to this lymph node basin. And that's what this next point is. It's a high risk of lymphedema. If you already had a complete lymph node dissection and then they get radiation on top of that, I definitely would expect lymphedema to occur after that as a side effect. So a local recurrence occurs within 2 centimeters of the regional site within 3 to 5 years, and it usually indicates an incomplete resection. A second primary melanoma somewhere else is about 2 to 3% in these patients, so they are a higher risk of a subsequent melanoma. For follow-up, if they have early stage 1 to 2A, every 3 to 12 months for 5 years, and yearly after that. If they're higher, near 2B, stage 3 and 4 is 3 to 6 months for 2 years, 3 to 12 months for 3 years, and annually. This is usually done by a surgical oncologist and their dermatologist, split treatments and follow-ups. And then treatment for recurrence, if it's a local recurrence, so within 2 centimeters of the primary, it's re-excision. If it's a regional recurrence, then it's re-excision with radiation or chemotherapy. Lastly, for melanoma, there is a thing called isolated limb perfusion, ILP. They put a tourniquet on the leg and infuse chemotherapy into that limb itself. These are done at a few medical centers like Duke, UVA. These are for unresectable disease. That's usually when there's multiple recurrences within the entire limb, and these are confined to clinical trials. So just something to keep in mind, but it's usually for unresectable disease, multiple recurrences and lesions after primary resection. You can consider this treatment for them. A couple more slides. Sorry, this talk's going long. So we mentioned this before as an indication for Mohs referral dermatofibrosarcoma protuberans, or DFSP. This is a low-grade malignant tumor that resides in the dermis. It's usually just a painless nodule or violet red plaque. Usually has a presence of several years, and they can report some trauma to that site. The treatment is 3 centimeters, including the fascia, to minimize the risk of recurrence. And, that'll be almost impossible in the digits. These are ones I would obtain a Mohs referral for these, because to get 3 centimeter margin on the finger, you're looking at a amputation. So it is this would prompt a Mohs referral in my hands for this type of for skin cancer. There are Merkel cells. These are one of the most aggressive skin cancer. These are in elderly patients. These originate at the basal layer of the epidermis. If you remember back to the histology side, these are usually rapidly growing, very quick, painless, and they're usually bluish and red. They can be an intracutaneous nodule or be fungating, like in this patient. You want to perform wide surgical excision with at least 2 centimeter margins, so 2 centimeter margins for this, and a sentinel lymph node biopsy is required for these type of lesions. And usually postoperatively, you are going to consider radiation and chemotherapy because of the high incidence of metastasis as well as recurrence. So you got to think of reconstructing options to support radiation after excision of one of these cancers. They are very aggressive with a poor prognosis. And lastly, there's eccrine tumors of the hand. These are very rare. I've never seen one. This is a photograph I pulled off the internet. These are slow-growing, painless lesions, usually in the elderly. They tend to be locally invasive, and these are treated with wide local excision. And the difference, and the thing that you need to know, there's not responsive to chemotherapy or radiation, so excision is your best chance for cure. So there's no role for radiation or chemo for the eccrine, but there is for Merkel cell. That's the last slide I had. I hope you learned something. Thanks for putting up with me for the past hour and 15 minutes. I hope you learned something today. Thank you.